Thanksgiving?
Yeah, we're so excited and welcome to everybody. We are so excited to talk about genetic testing and your fertility with my beloved friend, Natalie Richeimer, it's so wonderful to see you. How have you been?
I've been good. I just really excited to be here this afternoon, talk about something which I think is so important to anybody's fertility journey and to hopefully shed a little bit of light on this.
Great. Next slide. So we're going to talk a little bit about us here at Southern California Reproductive Center. We're in Los Angeles, California. We'll discuss genetic testing, fertility preservation options, answer any questions, and talk about our Thanksgiving special starting off the new year for fertility treatment options. Next slide. So at SCRC, we've been here more than 25 years. We're very proud that we've had healthy babies from embryos frozen over 20 years ago and eggs frozen over 12 years ago, which is a really big triumph. And our embryology lab is run by an amazing Dr. Jason Barrett, a PhD who's phenomenal. He really cares, and we all have intense meetings to get our success to the highest it can be. We have an in-house endocrine and andrology lab. Our hub is in Beverly Hills, but we have an office in Pasadena and a full lab and office in Santa Barbara too. Next slide. And so, like I mentioned, our Advanced Reproductive Technology Center, ART, is part of our team here, and they do a double witnessing verification for all embryo transfers and egg retrievals. They grow the embryos for 7 days. Some places it's just 6 days, but we've had healthy babies from embryos that blossomed by the 7th day. We do flash freezing, which is called vitrification, which is the most advanced way to freeze eggs and embryos at the 5th, 6th, and 7th day in the dish. We do pre-implantation genetic testing for both aneuploidy, which we'll go into the details, as well as single genes or X-linked disorders or specific genes that you may carry that you may not want to pass along to the next generation. The Embryoscope is a very unique incubator, and we'll show you some important pictures about that looks at the embryo over time, over those 7 days with 1,000 data points. And it really helps guide us to pick the best embryo to place inside for the embryo transfer. Next slide. I was born and raised in LA. I went to UCLA for undergrad and med school. And then I lived in Baltimore. I was homesick for 8 years in Baltimore. And it's been such a pleasure. I worked at Cedars for 7.5 years. And then I now have been here for 8 years as part of SCRC. And all throughout that time, I used our embryology lab here. So all the eggs and embryos that I've frozen over the years are still here. So I always feel like I'm sitting right next to them. So they're very precious to me too. Next slide. Natalie, would you like to?
Absolutely. So my name is Natalie Richeimer. I am a genetic counseling candidate at the Keck Graduate University Institute in Claremont. And I've been working with patients at all sorts of stages of their reproductive journeys, whether that's preconception before they're having babies, or whether that's while they're pregnant, or maybe that's after they've had their child and are thinking about maybe some future children. I'm really passionate about reproductive health education and community engagement. I had the opportunity to do a clinical internship this summer at Great Ormond Street Hospital in London. I've also worked on variant interpretation at ClinGen with Stanford. I am currently the student liaison for the Assisted Reproductive Technology Special Interest Group for the National Society of Genetic Counselors, and I'm currently working at Kaiser Permanente in their pediatric genetics department.
Awesome.
Next slide. So today we're going to talk a little bit about genetic testing. A lot of people have heard the words genes, genetics, and there's all sorts of research that shows that certain genes can be involved in certain health conditions or certain diseases. And a lot of the times we've noticed that certain genetic changes can cause somebody to be at increased risk to having a child with a birth defect or developmental disability or certain diseases, even cancer sometimes, or sometimes cardiological conditions like heart disease. Next slide. So let's take a step back and kind of learn about what are genetics, what are genes, what are all the stuff that everybody's talking about. Our bodies are made up of teeny tiny building blocks called cells. And in each cell, there's a set of instructions. We call those DNA. And those DNA are organized into giant, large suitcases. We call those chromosomes. A typical human will have 46 total chromosomes, 23 double copies. We get one set from our mom, and we get the other set from our dad. And inside the DNA, each individual instruction is called a gene. Next slide. So what is an abnormal gene versus a normal gene? I get that question all the time. Every single person is going to have a little bit of natural variation or a little bit of a change in their genes compared to others because we're all different. Even though we're human beings, we have things that make us unique, even within a family. You'll see a brother doesn't look exactly the same as another brother, even though they have the same parents. And that's because we have little changes in our DNA. Those changes aren't harmful. However, there are changes in DNA that can cause genes or those instructions not to function. And when those genes aren't functioning, that could lead to certain syndromes, conditions, and even certain illnesses. And a big thing to remember when we're talking about genes or DNA or chromosomes is that our bodies really like balance, which means that our bodies are happiest when we have the right number of genes and the right number of chromosomes, not too many and not too little. And if you do have too many or too little of our DNA, that can lead to certain health conditions or syndromes. So a big example that a lot of people will know of is that if somebody has 47 chromosomes, one extra chromosome 21, that can lead to something called Down syndrome. And somebody with Down syndrome will have specific characteristics. They'll have a very characteristic looking face. They're more likely to have heart defects. They're more likely to have intellectual disability. There are certain things where if you delete part of a chromosome, you're missing a whole set of instructions. So for example, on chromosome 22, you can have something called DiGeorge syndrome, where you have children who are of shorter stature, will have speech delays, developmental delays, intellectual disability, and all sorts of other conditions. Next slide. And so that kind of brings us into these terms, dominant and recessive diseases. What does that mean? What are there? Well, like I said, we have two copies of each of our genes. We got one copy from mom and one copy from dad. And what's nice is that a lot of the times, if one of the genes isn't working, there's a change in that gene that's causing it not to work, we always have a backup copy. So our bodies are happy to follow the instructions that do make sense, that do work, and people are just fine. And so they have one working copy and one non-working copy. We call people like that carriers. And a lot of the times people are walking around with a non-working gene that they don't know about. There's no impact on their health. They can live a completely healthy life being a carrier. What becomes an issue is if a carrier for a disease marries the carrier for the exact same disease, and they want to have children together, there can be a 25% or 1 in 4 chance that they will have a child that has 2 copies of the gene that do not work, or 2 non-working copies, and they would have that disease. So examples like cystic fibrosis. They also have a 50% chance or 1 in 2 chance of having a child that's a carrier like their parents. And again, a carrier is not sick, their genes are working and they're completely healthy. And then they've got a 1 in 4 chance or 25% chance of having a child that is not a carrier and does not have the disease. When we talk about dominant diseases are where, again, we have those 2 copies of our genes, but one isn't working. And for some reason, our body can't follow the other set of instructions. And so you will have diseases with that one set of instructions that are missing. And set that instructions that are missing or have those changes. If somebody does have a dominant condition, they have a 1 in 2 chance or 50% chance of passing that on to their child. And so again, these are all things and questions about if you know that there are these things in your family. There are a lot of great things that we can do. Next slide. So one of the things we should be doing and thinking about doing is something called carrier testing. Like I said before, so many people are carriers for diseases and they're walking around and they don't even know that. Some diseases are actually more common in certain ethnic groups, but anyone can be a carrier for a disease. And so a lot of couples will choose to do preconception testing before they choose to have children to see if they are carriers for diseases. And if they are carriers for the same disease, thinking about whether they want that to be passed on to their child and whether they want to be conceiving naturally or doing something like IVF. And we're going to talk a little bit about how IVF gives people an option to avoid that 1 in 4, 25% chance of passing on 2 non-working copies to have a child with a disease. Next slide. So the first set of testing that we have done is called PGTA testing. Now, when someone does IVF and sperm meet eggs, and we hopefully get a whole bunch of embryos, we can do testing on a few of those cells from the embryos. It doesn't hurt the embryos, and Dr. Alexander will talk about that. But if we can take some of those cells, we can look at the DNA, look at their instructions. We can look if there are changes or there anything extra or anything missing. PGTA stands for Pre-Implantation Genetic Testing for Aneuploidy. And aneuploidy basically means, are there extra chromosomes or missing chromosomes? It used to be called something called PGF, which is Pre-Implantation Genetic Screening. And this is going to be a procedure that a lot of couples will elect to do with IVF. And that's going to be looking to see that all 23 pairs of chromosomes are there. There's no extra chromosomes and there's no missing chromosomes. Next slide. PGTM, which stands for Pre-Implantation Genetic Testing for Monogenic or Single Gene Diseases, used to be called Pre-Implantation Genetic Diagnosis, is similar to PGTA in the sense that we are taking those cells from that early embryo, again, does not harm the embryo. And we're going to be looking at those instructions or those genes for specific disorders that their parents had carried for. Now, a parent and their partner needs to be testing in advance of this procedure so that they know exactly what they're looking for. But if they have what each parent carries, they can look and see if that embryo got 1 copy or 2 copies, and then they can go from there as a parent and choose to have a child that does not have a disease, and or they can choose to put in an embryo that is a carrier. But the idea is to make sure that we're not putting in an embryo with 2 non-working copies of the gene, which would cause disease in that child. Next slide. And Dr. Alexander has some really great patient studies about how this really works in real life and how this procedure and how this technology has helped so many people have healthy babies.
Yeah, that was such a good explanation. It made it so clear to me, and I know it, but it's so interesting to hear. Well, so I tend to lean on cases because it really brings home why we do this. But a very lovely 39-year-old came in and she knew she carried sickle cell trait. So she doesn't have sickle cell disease, she just carries the trait. And her partner got tested and he carries the trait. And so they came in, she was, over 35 too. So that's the neat thing about IVF is when we do check for chromosome testing, we can also check for the sickle cell gene. And 1 in 4 of the embryos get both copies. So we can avoid that embryo and use the embryos that are either a carrier like she is, or even not being a carrier, which can happen too. So it's kind of an important opportunity. The other thing is she can save an extra embryo because she really, really wants a chance for 2 kids and enjoy the first baby and not be into her later 40s realizing that then her egg supply has changed. So that case was really helpful, and then she saves the extra embryo for another opportunity down the road. IVF can be done to freeze embryos, and we check for many different types of genes: sickle cell, cystic fibrosis, Tay-Sachs, any situation that we're faced with. We meet with the genetic counselor and we have these intense meetings to see, can we safely determine from those few cells from the embryo that embryo doesn't have both copies from the parents. Next slide.
So another thing that is important to talk about with genetics is something called translocation. And it's something that many people haven't heard of. It's a little more rare. But basically, a translocation is when a section of the chromosome breaks off and switches places with another section of a chromosome. So you'll have, let's say, a piece of chromosome 21 all of a sudden jumping and switching spots with a piece of chromosome 20. Now, again, you have all the right pieces of your DNA, right? So that person would look healthy. It's what we call a balanced translocation. All the DNA is there. There's no missing or extra, but they have switched spots. And so what you have, again, like we talked about carriers before, a lot of balanced translocation carriers are completely unaware that they have this change in their DNA because they have all the right pieces there. No missing, no extra. And so they're completely healthy. But when their bodies are making either eggs or sperm, often the chromosomes can miss pieces or put extra pieces into that egg and sperm. And so what you have happening is that they may, or their partner may be having multiple miscarriages because that sperm has unbalanced chromosomes. And that can lead to something that we call recurrent pregnancy loss, which is going to be 3 or more miscarriages. And when a person is coming for IVF or just to be assessed with a reproductive endocrinologist, it's so important to give that information to them. I've had multiple miscarriages so that they can check if this is an issue for you. And this is easily detected by something called a karyotype. And in a karyotype, you would give a blood sample and they would literally paint a beautiful picture with the DNA in your cells and count and make sure that number one, you have 46 chromosomes, 23 pairs, but that all the pieces are in their right spots. And knowing that information can change treatment. If somebody does have a balanced translocation, there is something called PGTSR, which stands for pre-implantation genetic testing for structural rearrangements. And that is going to, again, look to make sure that baby has not only all the right chromosomes and the right number, but also that everything is in the right spot so that we can have a chance at a really healthy pregnancy and a healthy baby. Next slide. So before we get into other stuff, I did want to talk about direct-to-consumer testing because I'm sure some of you are thinking, well, I've done 23andMe and I'm totally covered because I came back totally fine. So direct-to-consumer testing is really fun. And I always say it makes a fun gift, but we as genetic counselors and we as medical professionals do not consider that medically actionable. And I want to explain why. These tests are not regulated and have very little oversight. That means that nobody's checking them to make sure these are good tests. So they may be saying that they're looking at your genes, but really how well are they doing that? Are they looking at it with their naked eye versus looking at it with a really, really good fine lens? So thinking about that. Also, when they're doing that and they give you these results, they're not doing that with a risk assessment. So when you come to a genetic counselor, you come to a physician, they're going to be testing specific genes based on your personal risk for things and making sure that they're making it directed, not just giving you a basic 2-3 genes, but it may include 17 to 200. So making sure that you're getting a robust panel is really important, that we're looking at all the genes that might be concerning based on your personal history and your family history, as well as they're not really robust. Even if they are looking at some genes, and a really great example is the BRCA gene, which can be associated with breast, ovarian, pancreatic, and prostate cancer. They're only looking at 3 different types of changes that can lead to cancer, but there's hundreds of changes. So if somebody doesn't have one of those 3 changes, doesn't mean that they don't have another one. And so that leads to a false sense of security for a lot of people thinking, hey, I did my BRCA test and I'm totally fine. But in reality, they didn't do a full BRCA test. And examples of direct-to-consumer testing are things like 23andMe, Ancestry.DNA. And so what I always say, it's a fun thing to learn about where your family came from and kind of maybe if, I don't know, some of them are if you like parsley or Brussels sprouts or other foods, and that's really fun. Definitely fun around the holidays, but this is not medically actionable information that you should be basing your reproductive health choices on. Next slide.
Okay, well that was such a great explanation. I have a lot of patients say they did those tests too. And I think it is still really valuable information, but again, like you said, it's not a deep dive into the genes. And so there can be things that we tell them once we do our carrier testing, and then patients are like, what, I thought I didn't have that gene. So it's important to think about it. Next slide. So there is always hope for the future. I always am a big believer that every month we have a good egg and we can have the good opportunity to have good sperm meet that egg. And so I'm just going to talk a little bit about options when people maybe for medical reasons need to take a medication and we may need to freeze sperm or eggs, or for future family building goals and embryo freezing. And especially during the pandemic, we had a lot of patients when we were on a severe lockdown that were facing chemo and big surgeries for cancer. And we were immediately freezing their eggs because we stayed open during that sort of scary time of the pandemic. So we do egg freezing often here. Next slide. So we take a detailed medical history. We really look at your menstrual cycle. We really are hoping to have regular periods. We talk about whether you've been on the birth control pills, whether or not you might have polycystic ovary syndrome or endometriosis, or could you have some fibroids in the uterus. We look at everything in detail. We do a physical exam and blood tests for diagnostic testing, as well as the ultrasound and a fallopian tube test to see how everything looks as you prepare to start a family. Next slide. The blood test called anti-Müllerian hormone level, AMH, can be done any day, anytime. It's not dependent on your menstrual cycle. It's a blood test that as we get older, it does go down. It's produced by the cells around your eggs called the granulosa cells. At any age, anytime, we're really hoping it's above 1, but when we're below 35, it should be above 1.5 and below 8. When it goes above 8, that's a little warning red flag for polycystic ovary syndrome. And so it's important to talk about avoiding inflammation, because a lot of women with really high AMHs are also a little harder for us to get them pregnant, because AMH, whether it's really low or really high, has quality of egg issues that we face too. Next slide. In terms of proper nutrition, it's important to eat mostly fruits and vegetables, avoiding the white carbohydrates. I tend to say have a free day, in the week. So think of nutrition over 7 days. And it's important to get all your vitamins, and vitamin D has anti-inflammatory properties. So it's important to have a vitamin D level 30 to 50, especially before an embryo transfer, because we have a little wiggle of time for that. So we try to titrate that level. We want to look at folate and B12 levels. In a lot of our patients here, we actually see very high levels. So it's important to also not overtake vitamins too. A DHA or omega fatty acids is really important for both egg and sperm quality. And the mitochondria, or the energy of the egg, is influenced by CoQ10 or ubiquinol, which is a vitamin that we encourage, especially the month ahead before you're thinking to do IVF, because we see that the momentum of embryo development looks better in women who are taking the CoQ10, and men, but they don't have to take as high of a dose as women do. Next slide. In terms of toxins, I feel like since the pandemic, I'm always talking about vaping and CBD oil and marijuana and stuff. So it seems to me that there's good things of not going out as much and that, but there's also this uptick in people potentially using other things to relax or sleep better, but they do have some ramifications for egg and sperm quality potentially. We don't know 100%, but it's important to try to lower excessive alcohol intake. Really avoiding hard alcohol for sperm is important. Marijuana may or may not affect sperm morphology and the quality of the DNA. So again, I tend to say to avoid that. Tobacco is really important because it makes sperm motility go down. It makes our ovaries age much quicker when we as women smoke versus women who don't smoke, their average age of menopause is different. And so it's important to think about that. I do educate patients that we can't look at the past because sometimes people get overwhelmed with too much of looking at the past. We can only look to the future and learn from what we've done and kind of move forward from there. Next slide. Our age matters. I had kids later in life, so I understand when patients are coming in or they met the right person at 39 and now they want to start a family. So I know how women feel when they're in that situation. But at age 35, we don't know why the chromosomes in the egg start to get sticky, and the mitotic spindle, instead of separating one chromosome at a time, like Natalie mentioned, it can take an extra piece of a chromosome. So when sperm comes in that egg, instead of having one copy of each chromosome, it had an extra copy, and that it can lead to a miscarriage or a problematic issue. And so it's important to understand that it takes a pool of eggs to get a genetically good egg, especially in women over 40. It takes even more eggs for us to get a genetically good egg. Next slide. In terms of the egg freezing process, we're asked this all the time. It takes a few weeks to get all your testing done. Some patients come in and they've already had their AMH, they've had their thyroid checked, their vitamin D levels good, they're already started all their vitamins, they're ready to go for the protocol. And the protocol is very individualized. I'm so proud of our group here at SCRC, but we really take pride in developing a detailed plan for each individual patient. We take into consideration your menstrual cycle, your BMI, your, all the health issues you may have. And so it takes 10 to 14 days of medication called follicle stimulating hormone. That medication's been around since 1962. And it does cause some breast tenderness, headache, mood swings, bloating. And during that 10 to 14 days, we bring you in for close monitoring to see how the follicles are growing and decide which day should be the egg retrieval day, which is a 20 to 30 minute procedure under light sedation. It's a very careful procedure. And that day, within an hour, the eggs are vitrified or flash frozen. Unless you want to fertilize them, then within 3 to 4 hours, they'll fertilize those eggs. The freezing process, we keep all the eggs here. We don't move them to a storage facility. And we have an entire big team of people to watch over that process. Next slide. This is how we do the egg retrieval. So the slide on the left is the follicles. Each black circle has one egg inside potentially. And as the 10 to 14 days of medications, the follicles grow to a certain size so that we can get a mature egg. This is the needle coming in through the wall of the vagina directly into the ovary to get the egg to come out. Next slide. In terms of the process, you are sedated so you don't feel this, and the thin needle goes through the wall of the vagina into the ovary, and we carefully get the egg out. Next slide. So how many eggs do we need to have a healthy baby? We've had patients have a few eggs and get a really good embryo and get pregnant. We've had patients have a lot of eggs and their future partner's sperm is not optimal, and that has made it harder for us to get normal eggs, normal embryos. But on average, if we're under 35, we're hoping to get 15 or so eggs, and that gives us about an 85% chance of a pregnancy. When we're over 35, it does take more eggs. We did a 5-year analysis, and at 37, it took 17 to 20 eggs. At 38, it took over 20 eggs. So it does take a lot of eggs to get an opportunity for the future. Some people harvest a group of eggs, they get 5 to 20 eggs, then they take a little breather, regroup, and think if they want to do this again. I've had a lot of patients over the years just get one good group of eggs and then recheck their AMH a month or two later to watch the trend. And if it's trending downward, they freeze another group of eggs. So it's a very personal decision what feels right to you. Next slide. In terms of embryo development, I love this picture. It's so beautiful. But the fertilized egg goes to 2 cells, then to 4 cells, then to 8 cells, to 1632, and then to 100 cells. Pre-implantation genetic testing, we take 3 to 4 cells from the trophectoderm, which is the outer rim. The inner cell mass is what becomes the pregnancy. And our IVF success for 2021 has been 78% with a normal embryo. It's been really high, I think, because a lot of people aren't eating out as much and aren't traveling as much. But we've improved our success rates even from last year, the year prior to this year. So we work really hard to make sure the uterus is ready for the embryo as well. Next slide. So this is a picture of how we do the biopsy. We take the few cells right here off the outer rim, and our team is very careful when they do this. And those cells go to a genetics team, and the embryo stays here and is flash frozen here. Next slide. This is ICSI. This is a sperm being placed into the egg. When we're doing PGTM, we have to do ICSI because we don't want a chance of extra sperm wiggling on the outside rim of the egg that could disrupt the accuracy of the genetic testing. So we actually want 1 sperm going into the egg, and we go perpendicular from the polar body, and that's called intracytoplasmic sperm injection. This helps men who have low sperm motility too, or a low sperm count. We use a high power microscope to find the best looking sperm to put into the egg. Next slide. Next slide, sorry. This is a beautiful image of the Embryoscope data. And so right here, there's 2 cells. And then the embryo is going to go to 4 cells, then to 8 cells, and then it'll evolve to 16 cells. And then this is called a morula, and then it becomes a blastocyst. And this is the inner cell mass, and the trophectoderm's on the outside. Next slide. In terms of genetic testing and age, what's also fascinating is in the past, in the old days, when we didn't have genetic testing and we would have a woman in her 40s, we would put the embryo in and hope for the best, and the pregnancy rate was maybe 20% or even less. And now, because we're able to overcome a lot of chromosomal problems, we're almost similar to as if we were younger. And so if we can get a genetically good embryo, we've improved our pregnancy rate over time. Next slide. Our team here is a wonderful team. We work all together. We all put a lot of heart into the process to help you have a successful outcome, a healthy baby, and get through the process safely. And we each take care of our patients individually, but we work together and chat and have really amazing meetings to improve our pregnancy rate. Next slide. And if you'd like to schedule a consultation, I'm happy to chat with you. Mention the Genetic November webinar. That gives you half off, and I look forward to seeing anybody or answering any questions. Next slide. We're doing a special Thanksgiving special, so if you'd like to read about these, I think I've had a few friends of mine from college do egg freezing together, and they felt like they had a buddy in the system, so that helped them get through the shots and through the process. Our team, my nurses, Angelica and Leanna, are really hardworking too and put a lot of TLC as well. And Natalie, any comments? I know I was talking.
No, just, I mean, I truly believe that SCRC is one of the best in the city. They have the most amazing team, but the doctors are also so kind and just treat you like they're your own family, and just feel so privileged to have the opportunity to work with Dr. Alexander, but that other people get to experience her amazing care as well.
Yeah. Well, I see some questions here. I don't know if you...
I see one. Yeah.
Will you answer the first one then?
Absolutely. So the question is, how often should we be retesting as the technology or test parameters change for carrier screening? So I would say it's really important, number one, to be taking that information to a genetic counselor, showing them your past testing. A lot of the testing that we did 15 years ago, 20 years ago, the panels of the amount of genes that we were looking for were small. So I think about myself personally. The panel that I did had 15 genes on it. The panel that I re-updated quite recently had over 200. And so there's quite a difference. I would say it's a good thing to be updating testing about every 3 to 5 years. And that update may or may not be necessary, taking that information to your genetic counselor and saying, hey, is this still good or should I be updating? But if you've done testing a year ago or 2 years ago, it should be more than substantial.
That's a good point. And also when you're picking, some of our patients are picking a sperm donor or same-sex couples, and they may have done genetic screening previously, but then they really love this one donor and he carries, you know, rare kind of one random gene like biotinidase deficiency. And then when I look at her panel, she hasn't had that one. So then I have to have her get that gene tested or else she can't pick that specific sperm donor. So I think it's important to double check both that if your partner carries a specific gene, that we check that you for sure don't carry that gene. In addition, like with Gaucher's, which is not common, but sometimes there's a special panel we can order in different ethnic backgrounds that can look deeper into the gene if your partner carries a specific gene. So a genetic counselor is so critical to this process.
Yeah. And I would just add to that as well. If you are a carrier for something, like we said, there are options. So you're in the right place. PGTM is a great option. And it's something that allows so many people to have those healthy children. So I think we always kind of get nervous about opening the Pandora's box, but that information can be really helpful for you to have before pregnancy.
Yeah. So I see a question here about the size of the follicle. That's a really good size. That in our doctor's meeting today, we were all going over that. So the way our ultrasound team measures, we have all gotten used to it because we have worked all together for years and years. So we're hoping to get them into the 20s. But my colleague on the East Coast, that at like 18, 19, those are mature for them. But for us, we've seen that most women take around 11 days of medication, and most people have to have 3 follicles at least into the 20s for us to get a group of eggs that are mature. We take it into consideration because a question here is if over 40 years old, should we trigger people at like 16, 17, 18? But it's so disappointing if you do that and you only get immature eggs. So it's a case by case situation. In my PCOS patients, I notice if they take melatonin 5 milligrams a day through the protocol, I tend to get a more mature cohort, even if I have to trigger them early for a high estrogen. But you can ask your doctor, or you're welcome to chat if you have any questions about those specific things. Here's a question about human growth hormone. It is helpful in women over 38. There's a Cochrane review in the scientific journals. We use it during the stimulation, and sometimes if a patient comes in for a second opinion and has had all abnormal embryos on PGTA, then what we do is the month prior, we'll give twice a week dosing for growth hormone. And I don't know why, but somehow we seem to get more normals that way. Do you see any questions you want to answer?
Yeah, there's a great one about a VUS, if that's okay. So the question is, how does genetic testing work for genes that have a VUS mutation? So great question. I'm gonna just backtrack a little bit for everyone who's watching. What is a VUS? So when we do a genetic test, there are kind of 3 results that we have. Number 1 is a positive result, meaning we see a gene change that we're looking for, or a gene change that we know that can cause the gene not to work. Negative means that we haven't found a gene change that we know about that doesn't cause the gene to work, and that's a no for us, or the gene that we're looking for. And then the third one is a little bit of a strange one, which is something called a VUS, or variant of unknown significance. I like to think of it as a question mark or inconclusive, which means we see that there's a gene there with a change. We don't know what that change does. We're pretty sure it's fine, but we're not 100% sure. So it's a wait and see. Most of the time, those genes are reclassified with that VUS to being benign, meaning non-harmful. Sometimes in rare situations, it's upgraded to being pathogenic or likely pathogenic, which means that it could cause a change that is harmful to the gene and causing it not to work. I think it's very, very important to be talking to a genetic counselor depending on the gene. So in cancer, we see VUSs all the time, and we don't really think much of them in cancer. We kind of don't do anything differently. We'll watch them to make sure that nothing is changing in the data, but 9 out of 10 times they're usually downgraded. However, in things like neuro or like neurology, if we're seeing a gene change with the VUS, we don't know as much as we do about cancer as we do with the genetics with neurology. And so a VUS is kind of a bigger question mark to us. And I think it's much more prudent to be talking to that genetic counselor and seeing if this is something that I should be concerned about, or it's probably a nothing. And so I think it would really depend for those type of genes. Generally, we do not look for VUSs. We always in genetics want medically actionable genes. So if there's nothing we can do based on that change, we're not going to go hunting for one. So I would say always really great to be talking to a genetic counselor about the type of VUS you have and the type of gene that it's in, because those will give you those 2 pieces of information. And there's another great question over here about should both partners get genetic testing? And I believe this is for carrier testing at the same time, or is it okay to wait for the results of one partner? That is a preference thing to me. So in my opinion, I think it's great to do it at the same time because we get the information back at the same time and then we can kind of move. If for some reason maybe a partner is unavailable and they can't do that test and they have to wait, it's totally fine. It just might, again, slow down that process if you're somebody who's really excited about doing, retrieval and transfer at a certain timeline. Pushing your partner to do that later will get your results later and will kind of slow that down if one of you is tested as a carrier. So just up to you and your partner's preference.
Yeah. Great. We don't put, there's a question, does SCRC put all patients on birth control pills? No, if your FSH is high, it's important to be very gentle with it. I tend to not use birth control pills too much, but it just makes us have to prepare ahead of time. And lately, since the pandemic, we do see a lot of patients over 40, and sometimes the birth control pill can be a little difficult in recruiting the follicles. But some people with PCOS really benefit from lowering the testosterone so that we can get the best quality eggs to pop up. Some of our patients have a lead follicle and that messes up and disrupts the group of follicle recruitment. So their birth control pill has a lot of benefits in some circumstances, but it's a very case-by-case situation for us here. It says, should we start a prenatal before having IVF consultation? Well, that's a good question. I think the folic acid's really important ahead of time and vitamin D, but it does, if you're going to have an embryo transfer, it's really important 3 months prior to be on your prenatal vitamin. And then for another question was, when do we use steroids? Steroids are also very case by case dependent because you want to also lower adrenal androgens, because with PCOS or congenital adrenal hyperplasia, the testosterone's pumping out high from the adrenal glands. So we have to sometimes use dexamethasone or steroids. Some women with recurrent pregnancy loss are in a pickle. Their body gets pregnant, but for some reason the immune system acts strange. If we can't find a cause for the miscarriages, then steroids or prednisone can be beneficial. And then she froze her eggs at 37 and is now 45. So we help women into their 50s. We do require an EKG within a year, mammogram within a year, pap smear, and a physical with your primary care doctor, because when we're over 45, the vascular flow to the uterus is a little decreased. So it's really important to exercise. It's like preparing for the Olympics. So you want to be as fit, cardiovascularly fit as possible before we put the embryo inside. But that's a really good question. Is there a difference in the embryo implanting if you're 45 versus 40? That's a tricky question. I don't think so, but I think a lot of our patients here are very slim and fit and Pilates and eating so clean. I think it's different if someone's BMI is not optimized or they have chronic hypertension or have ever had rheumatoid arthritis or lupus or something like that, because the microvascularity to the uterus is a little compromised. So it definitely depends. But I think in general, a genetically good embryo always tends to want to stick so much. So whether you're 37 or 45, I don't know if it really makes a difference. If that embryo is really good, it's going to implant. Any other questions? What causes the AMH to fluctuate? That's such a good question. I know there's some evidence that if you've been on the birth control pill for like 10 years, and then we check your AMH, it can be falsely low and scare patients. They're crying. I'm telling them, take a break, take a deep breath. Let's recheck it, stop the pill, take a breather from the pill, and then I'll recheck it a month or two later and it's normal. And I'm like, this is so interesting. So I've seen many times. I think with some of our PCOS patients, we see it at a high level, kind of yo-yo back and forth. That's a reflection of inflammation. So avoiding inflammatory foods. Sometimes I make people do a gluten-free diet, but AMH is there's no perfect, it's not a perfect test for sure. Is DHEA okay to take if your testosterone's low? It's better to take if your testosterone's low. So I hope I answered your question.
Where can you sign up from genetic testing? I believe SCRC has a great company that they work with to get you that carrier screen and get you set up with a genetic counselor. Is that right, Dr. Alexander?
Yes, yeah. So you can come in for a visit. You could also ask your OBGYN, but we would check the genetic carrier screening.
And if you do have, if you do have previous screening that you've done, make sure to bring that with you to the appointment so the genetic counselor can help you as best they can and make sure that they're ordering all the right stuff for you.
Oh, there was one more question I see. I'm 43 miscarriages in the past 18 months and we keep getting pregnant, but the AMH is low. I think of the AMH as a little red flag, that there are eggs there, but we have to get the quality eggs to pop up. And so with the IVF protocol, you would want to be a little more gentle with the stimulation. I think anytime I think of 3 miscarriages in a row, there's 5 main categories. You're welcome to do a video call and we can go over all the categories, but we also sometimes find that the sperm is the problem, not always just the egg issue. And so with miscarriages, it's important to look at all the categories to understand what's the issue. And then with the AMH issue, time's not for sure on our side. So it's better to get an evaluation sooner than later and talk it out your options too. Good. Any other thoughts or any other questions? Natalie, do you have any other thoughts?
No, I was just going to say to that last question, to this individual who has gone through those 3 miscarriages. It is so hard, and I hope that you're getting the support that you need. And just know that somebody like Dr. Alexander doing a good workup can hopefully get you some answers to that. So I'm sending a lot of love just your way. It's any type of pregnancy loss at any stage is hard, and hope that you are getting the support that you need.
I know. And the fact that your body gets pregnant, I always think that the system really wants to be pregnant. So if we can get a genetically good embryo, it tends to be a little easier to get you pregnant again. But happy to go over any thoughts or questions on that. Well, it's so nice to see everybody, and our team here we do video calls, so we can not wear the double mask and the face shield and the goggles. So it's kind of nice. And if you need anything, feel free to give us a call. Thank you, Natalie, too.
Thank you so much. And it was such a pleasure to spend time with you, Dr. Alexander, and to get to answer your questions.
Yeah, take care.
Take care. Bye-bye, everyone.
Bye.